this, it says epicardium, endocardium, and myocardium, but it's a little picky, I think, to ask you to learn the difference, be able to recognize. If you have both, I'm going to be able to recognize the difference between them. So what I really want you to know for histology is the myocardium. Okay, I'm going to show you some histology of the endocardium and epicardium, the outside of the heart, and then we'll look a little bit. Epicardium is the same as the visceral serous pericardium. And so those are just both names for the same component. So the endocardium, the endocardium is a lining of simple squamous epithelium, which is continuous with all the blood vessels that carry blood away to or away from the heart. And it's got underlying connective tissue. That's also where we would see conductive cells. So the SA node and the Purkinje fibers and so on, we'll see some of the Purkinje fibers. The myocardium, of course, are the intercalated muscle fibers, the branch fibers. And the epicardium, as you'll see when you see the actual sheep hearts, has a lot of adipose tissue. That's what protects the surface of the heart, protects the blood vessels. I told the class last night when we first got our cadavers, one of the dissectors wanted to dissect out the blood vessels for the heart. Just taking the fat off to be able to see took about 4 hours. Just carefully removing the fat without tearing the vessels. So again, you can see a comparison between, now it's split, the epicardium is now on the top and endocardium on the bottom. And this is the epicardium again, simple squamous epithelium. And again, the fat. And here are the muscles, all right? They share characteristics of both smooth muscle and skeletal muscle. Of course, those have the smooth muscle and cardiac muscle are both innervated by the autonomic nervous system. However, and the smooth muscle has one kind of spiral nucleus. Cardiac muscle has also one nucleus per cell, kind of boxcar or rectangular shape. But as I move to a higher powered view, those of you in the front may be able to see it, and I'm almost too close to see it, but you can see some striations, some light and dark, some pink lines. If you recall from skeletal muscle, they're also striated, alternating portions of the sarcomere that are light and dark. Myosin's dark, actin all by itself is light. And so skeletal muscle has a very similar, has that same type of alternating actin and myosin, and in smooth muscle, it's all branched and it doesn't overlap in an organized fashion at all. So the intercalated disc that you see here and here and here, you can see a little bit darker on this image, is where two cells have formed junctions. And the reason they stand out dark like that, we don't always see plasma membranes really well together, is because this is why we call them intercalated. This would be muscle A and muscle B, okay? So components of two muscle cells would intercalate for their cell junctions. Now, I don't know if you remember, but, because we'll talk about it on Tuesday when we talk about cardiac physiology, what kind of, do you remember the three types of, major types of cell junctions from first semester?
A gap junction.
We had tight junctions.
Gap junction.
You might have learned them as zonule adherens. That's a Latin term for the desmosomes. And gap junctions, okay? When you look at these two muscles, ignoring this part of the diagram here, when the cardiac muscle contracts and the muscle cell shortens, it puts tension on those junctions. Where do you think the highest amount of tension is going to be between the two cells? Here, where it's vertical, or here, where it's horizontal? You think of the cells shortening and creating tension against each other. Vertical or horizontal? The horizontal is going to have a shear, kind of sliding effect. The vertical is going to be pulling directly perpendicular to the membrane. So the vertical is where we have the desmosomes, and I'm just drawing one larger one with the intermediate filaments, because that's where the most stress is, going that way and that way. And then, anybody know why we need gap junctions for muscle cells?
The ions.
Ions, exactly. Cardiac muscle cells are not innervated. In the skeletal muscle, every muscle cell has at least an synaptic gluton from the neuron, at least one, usually several. So there's a direct release of neurotransmitters to the muscle cell. In the cardiac muscle, it tends to kind of just drop, kind of like the sea urchin sperm dropping over the egg. The neurotransmitters are just released from little swollen areas of the autonomic neurons, and they just kind of float down. So there's not a direct one-to-one relationship. So we get our wave of contraction downward from the atria and then upward from the ventricles because of this. It's not like a nicely choreographed release of neurotransmitters. It's the muscle cells themselves depolarizing and then sending their ions through gap junctions. So sodium and calcium ions pass from cell to cell through those gap junctions, okay? And all of those junctions and the overlapping membranes is why we see the intercalated disc. So that's essentially what I want you to be able to identify in histology of a cardiac muscle cell, would be what the striations, the overlapping actin and myosin, the intercalated disc, and the nucleus, okay, that we saw in the previous slide. Okay. Now, this is just for fun. We're going to be looking at the conducting system next week. So we're in the endocardium here, the lining of the heart. And these swollen cells, our conducting system in the heart is not neurons. It's modified muscle cells that have very little actin and myosin anymore, and a lot of glycogen. Remember how swollen and white the uterine gland tissue became after ovulation? Because it would supply glycogen to if there was an implantation. And these muscle cells have that similar swollen white look from the glycogen that's present there. Okay, these Purkinje fibers are the ones that, again, we'll talk about them next week, but you can see them in the models, at least in this particular model, as the white lines forward. So the red tissue is the myocardium, right? The black is connective tissue, and then the dotted green line is simple squamous epithelium. So we have the endocardium, which is the black connective tissue, and our valves and chordae tendineae are only our collagen fibers. All right, so that's all connective tissue separating the atria from the ventricles as far as conducting cells are concerned. And so the inside of the heart is covered with a simple squamous epithelium, and that in the connective tissue is the endocardium. You're used to that term because of endometrium. That's the lining on the inside of the heart, continuous with the blood vessel lining, so a simple squamous epithelium. All right, so what I want to draw now, a little larger view, is the myocardium up near the base of the large vessels, and I'm going to leave off the endocardium. And so it creates as if the heart was to grow into a bag, right? Sometimes people think that the heart is inside the pericardial cavity, but it's not. As you can see here, just like for the lungs that we'll talk about next, this is a closed space. It has a little bit of fluid. I made the mistake of putting fluid in my plastic bag to illustrate that last night, and it spilled all over Mark's table. So I'm not going to do that tonight. I got one of the heart off of the model in the back, and I got a plastic bag from our lab room. Okay, so this is a closed bag. The space inside is not a lot. It's about 15 to 20 mils of fluid that's in there. And as the heart grows from the mesoderm, it kind of pushes into that sac, and the sac attaches to the heart wall. So if we were to open up a chest from the model, or someone needs open heart cardiac surgery, which I don't think any of us are qualified for, but you open up the sternum, use rib spreaders to spread that out, okay? And what you're going to see, you're not going to be able to see much of the heart because you're seeing the outer parietal pericardium and the inner or visceral pericardium. You're looking through, from the front, both of these layers, okay? So to get access to the heart, and this is kind of backing together then, we need to cut, and you'll see this on the sheet part that I bring around. Parietal pericardium, and then while you're dissecting your sheet part, the smooth, shiny surface is still going to be the visceral pericardium. Okay? The parietal pericardium lifts off, the visceral pericardium stays attached to the myocardium. Now, the outer layer is not going to look very tough on the sheet part that I show around, but this outer layer has a lot of dense, irregular connective tissue. None of our other organs that have a membrane around them, like the lungs or the stomach or the liver, their parietal membrane, pleura or peritoneum, doesn't have that tough outer layer, all right? We'll come back to that in a minute. The inside is simple squamous, just like you see here. And then it folds back on itself at the base of the aorta, the superior vena cava, to attach to the heart itself, and that simple squamous epithelium is continuous, all right? Sometimes if I talk about this in the winter and I'm wearing a jacket or sweater, or someone's got a jacket on and a silk shirt, and the jacket's lined in silk, that outer wool of the jacket would be the fibrous, parietal fibrous pericardium. You open up the jacket, the satin lining is the serous parietal pericardium, and then the shirt, we can make it reflected onto the shirt, would be the visceral serous pericardium. Okay, so it's all, that serous part is that simple squamous epithelium. So, I'm going to draw the connective tissue of the visceral serous pericardium. It's going to reflect off to become the parietal pericardium. And then we'll add so this is a combination of loose and dense. It's kind of depends on where we are. Then we add a dense irregular pericardium to the outside to toughen that up. So it doesn't tear or stretch, and we'll come back to that purpose in a moment. All right, so this fibrous pericardium, so parietal, and I don't care what order you put these words, fibrous parietal or parietal fibrous pericardium is what you're going to see if you open up the heart and look down at open up the chest cavity and look down at the heart, okay? Then we have the simple squamous epithelium that's lining the cavity. This is where the serous fluid comes from the loose irregular connective tissue through the epithelium to fill the pericardial cavity. All right, so that's simple squamous epithelium. And then the solid line, as I said, would be a combination of loose and dense and adipose tissue. And then this would be the visceral serous, when you're actually touching the surface of the heart. What's another name for the visceral serous pericardium?
Epicardium.
Epicardium. Right, so when we're talking about the layers of the heart, you'd have epicardium, myocardium, endocardium. But if you want to use the long word, visceral serous. All right, and then this dark solid line without the fibrous part would be the parietal serous. Alrighty, I'll put epicardium in parentheses here. Now, back to that fibrous pericardium. The purpose of that is to prevent cardiac muscle from overstretching. You if you remember from muscle physiology, anatomy stuff, if a muscle overstretches and the actin and myosin aren't overlapping each other, then contraction is very weak. All right, there's a maximum point, not where they're totally contracted, but somewhat overlapping that we have the best force. And if they overstretch, then they lose that force. And so the fibrous pericardium keeps blood from filling up the chambers of the heart so much that the heart overstretches. The problem with that, though, is fluid can get into this pericardial space. It can maybe a stab wound or a bullet that allows blood to leak into there. I told the class last night, hospital that I worked at about 6 to 8 months before I got there, they were telling me the story of a young pregnant woman, in the 20s, who had come to the hospital. She was about 6 months, and she had pneumonia, and she wasn't able to breathe very well, and they started an IV. Maybe it was for parenteral alimentation. Maybe she was throwing up too much, because they put it in her subclavian vein, which is where they put that type of an IV that you can use a larger needle. She got worse and worse. And they finally took her to take x-rays, and the needle, instead of being in her subclavian vein, had passed through it and into her pericardial cavity. And that fluid was filling up the pericardial cavity. So would that cause her heart to beat faster or slower? So when your heart beats, everybody last night said slower too, the answer is faster. When the heart beats, it sends out a volume of blood. We'll learn this in Thursday next week. One stroke volume is the volume of one contraction of one ventricle, okay? And your heart tries to maintain a normal volume of circulation and a normal blood pressure. So can it increase as blood is flowing into the ventricles and there's fluid around it? Can it expand to receive as much blood? No, because it's limited by that fibrous pericardium. And so with fluid in the pericardial cavity, it can't expand outward because of the fibrous pericardium, so it expands inward and limits the ability of the ventricles to fill with fluid, okay? So then they could only fill with, instead of 135 mils of blood, they could only fill with 100 and then 80 and then 60. So if it could only contract, normal volume is 70 mils to pump out. If it could only pump out 35, then it's going to have to pump twice as fast to get the same volume of blood out every minute, okay? So it's going to have to pump like this because it can't pump like this. Just like the stronger heart you have, the lower heart rate you have. The weaker heart, the faster, because it can't pump as much each time. You've probably heard of a weak and thready pulse or a rapid thready pulse. That threadiness is because not much volume of blood is getting out of the heart with each contraction, and so your pulse doesn't expand very much. Okay, so did I tell the story about my chemistry friend, the soccer player? Didn't? Okay. Last story about the pericardium. So when I was first started teaching in Tennessee, I was only 23, and there was a 25-year chemistry teacher who thought he was still one of the college kids. And he would go out every Friday afternoon and play soccer. Well, one Friday afternoon, he and another soccer player just their chests slammed together like that, and they both fell back on the ground, but other than losing their breath, they were okay. So the next morning, he had chest pain, and his dad had had heart issues, so he said, this is a heart attack. I'm going to find out by push up some jumping jacks, and if it hurts worse, then it's a heart attack, and I'm going to the hospital. Well, it still hurt, but it didn't hurt worse, so he thought, this is a very true story. I'm going to run up and down my stairs, and if it's a heart attack, it'll hurt worse. I don't know if he said, well, then I'll just die, but it didn't get any worse, but it still hurt, so he lives on a hill. So he goes, I'll run up and down the hill. Finally, he took himself to the hospital in the ER, and what had happened was when the sternum slammed against his heart, the two inner parietal serous and visceral serous membranes sheared past each other and just scraped off that simple squamous epithelia. And his pericardial cavity was filling up with fluid from the connective tissue lining that area. That's where his chest pain was coming from. So they gave him antibiotics, sent him home, and said, the next time your heart hurts, just come to the ER. All right, so when we look at the heart, we're going to go through one drop of blood at a time, okay, rather than the cycle that the heart beats with. So deoxygenated blood comes from the head and upper limbs and chest through the superior vena cava. From the abdomen and the lower limbs, it comes through the inferior vena cava. And then from the heart, the great cardiac vein, which starts here in front, goes around the side. It dilates to become the coronary sinus. So the blood that the heart has used to contract gets deoxygenated, and that's how it returns. It doesn't go very far, back to the right atrium. So you can see it. It's going to empty in right there. When we look at the sheep heart, we'll be able to find the opening for the coronary sinus, right near the inferior vena cava. All right, so blood is now in the right atrium, and it's auricle. Here, the right auricle. Both the auricles for the atria have these comb-like ridges of muscle called pectinate muscle. Ridge-like muscles in the ventricles are called the trabeculae carni. Okay, the rest of the atrium is smooth-walled, and so that red circle right there is the inferior vena cava that has a kind of white arc around it. That's the opening for the inferior vena cava, and that smaller opening right beside it is for the coronary sinus. Okay, it's right where the inferior vena cava comes into the heart. And there would be the fossa ovalis, which is an embryonic development structure that allows blood to move from the right atrium to the left and not go to the lungs. And we'll talk about that when we start talking about fetal circulation. Okay, blood from the right atrium when the heart is relaxed just continues to flow into the right ventricle, which is going to have a thinner wall than the left. That's one way we'll find out where we are in the sheep heart. And the ventricles, both right and left, have these trabeculae carni. Okay, the right ventricle valve only has 3 cusps, and so tricuspid. I prefer to call it right atrioventricular, but tricuspid is fine. And connective tissue bands called chordae tendineae attach from the valve leaflet to papillary muscles. And those papillary muscles adjust the tension. They don't pull the valve closed. They keep it from blowing out, turning inside out. So they will adjust the tension. You'll be able to see them quite well in the sheep heart. So it's there and there. And on the left side,
My question on here is why is the coronary tendineae the same number as the papillary muscles?
I have no idea. Well, it's pointing to this, this would be the chordae tendineae here, the white.
Oh, so it should be
So it should
labeled
say,
out there.
yeah.
Oh, okay, gotcha.
All right. Then when the ventricles contract, blood goes out both the pulmonary trunk and the aorta, but we're following 1 drop of blood. So the other valve is right here. Each semilunar, we have only 1 valve that has 2 leaflets, and that's the left, because the right atrioventricular has 3, the left ventricular atrioventricular has 2, and all the semilunar ones have 3. So these are under low pressure, much lower pressure. They don't have chordae tendineae, and they will fill as blood flows back towards the heart at relaxation. So there's 1 valve leaflet and the 2 others, and blood then goes out the pulmonary trunk to the pulmonary arteries. Notice it's blue though, so it's called an artery because it's going out under pressure, whereas veins are returning under low pressure. So it doesn't matter whether it's oxygenated or not. It's the structure of the heart, and all the vessels carrying blood away from the heart need to resist pressure. So it's going to be a thicker vessel, and so it's called an artery because it's carrying blood away, even though that's deoxygenated. It can go to the right lung via the right pulmonary artery, or the left lung via the left pulmonary artery. Okay. This structure right here was open, a short connection between the left pulmonary artery and the aorta as another bypass for blood to not have to go to the lungs in the fetus. After birth, it closes and becomes a solid cord, and that's the ligamentum arteriosum. Okay. Then blood comes back from the heart after it's picked up oxygen. That's why these are painted red, via the pulmonary veins, 2 from each lung. You won't see that in the sheep heart. It's just going to be one big hole where they lopped it off close to the heart. It then returns the left atrium, and this would be the left auricle with its own pectinate muscle. Goes through the left atrioventricular valve, bicuspid or mitral, and it also has trabeculae carni, papillary muscles. All right, now one thing I neglected to mention was in the right ventricle we have a cord of electrical conducting cells called the moderator band. They don't show them in the models. They are in humans, and we'll see them in the sheep heart. Okay, and it helps to detect the right ventricle as well. All right, once it then, the left ventricle is pumping, it goes out the left aorta, which is tucked up under here, kind of behind the AV valve. So if you look up in there, you'll see the semilunar valve for the aorta. Okay. All right, and then blood goes to the body. Now, when it leaves the aorta, we have the right coronary artery and the left. Those are the first two vessels to come off of the heart. And so the right coronary artery goes all the way around between the atria and the ventricles, all the way around, and it gives off the posterior interventricular artery. On the side here, it gives off the marginal. So I want you to know right and left, and then two branches for each. So right coronary artery kind of swings around like a belt. At the side, the hip, it gives off the marginal. And the very back, it gives off the posterior interventricular. Between the right and left ventricles, it's a good way to separate those two ventricles, okay? Then on the left side, the left coronary artery is very short. It's gonna come off the aorta behind the pulmonary trunk. It's only about an inch, inch and a half long. And then immediately gives off the two branches that I want you to know. So coming down the front, the right has the posterior interventricular, the left has the anterior interventricular, okay? And then the circumflex does what the right coronary artery does by going around the waist of the heart, so to speak, like a belt, and then those are you don't have to know any branches off of the circumflex, okay? And then your lecture notes, I pair them with the veins. So we have 1, 2, 3, we have 6 arteries and 3 cardiac veins. So we talked about the coronary sinus. It starts here with the anterior interventricular artery as the great cardiac vein. Some textbooks will call it the anterior interventricular, but then it changes names and we might as well just stick with one. So we have 3 cardiac veins. The great starts at the front, then we find it with the circumflex, and then finally it dilates under the left atrium to the right atrium where it empties into the heart as the coronary sinus. The other 2 veins empty into it right here. So with the marginal artery, we have the small cardiac vein coming around to the coronary sinus, and that's one way to find the marginal artery. See how that makes a right angle turn? So if you see that, then you know that that's the marginal artery, okay? And then coming around, coming up from the posterior interventricular artery, we have the middle cardiac. So great cardiac forms the coronary sinus, small cardiac and middle cardiac drain onto this end of it here just before it gets into the heart. Small cardiac is going to start in the front. So it's going to start here where it makes that bend and travel all the way around till it empties into the coronary sinus. And then that would be the middle cardiac. Okay. Now in the front, we have a few anterior cardiac veins that don't go into the coronary sinus at all. They just go straight into the right atrium. So that's just showing one of them. Kind of a lonesome. Okay. All right.